Trace and toxic elements, just iron and TIBC. So iron, it's the distribution anyway. The majority of body iron is found in hemoglobin within red blood cells. Smaller amounts are present in myoglobin in muscle tissue. Storage forms, iron is stored mainly as ferritin and hemosiderin. Storage sites include the bone marrow, spleen, and liver. Iron recycling and absorption. When a red blood cell dies, iron is recycled from hemoglobin. Intestinal absorption of iron is the key regulatory step controlling total body iron levels. Physiological roles of iron, it's essential for oxygen transport via hemoglobin and is also vital for cellular respiration and oxidative metabolic processes. For normal saturation levels of iron, under normal physiological conditions, both storage ferritin and circulating transferrin are only partially saturated with iron. Transferrin, that is the primary transport protein for iron in the bloodstream. It binds iron and delivers it to various tissues, including the bone marrow, for red blood cell production. Iron deficiency anemia, so at-risk groups for this is children, pregnant women, adolescents, which I guess would be children, and women of childbearing age. Causes is increased blood loss, so menstruation, if they have a GI bleed, decreased dietary iron intake, and decreased release of iron from ferritin storage. For laboratory findings, we will see a decreased red blood cell count. We will also see, if you've taken hematology, microcytosis, which are smaller than normal red blood cells. We'll also have a decreased red blood cell indice, which means a low mean corpuscular volume and a mean corpuscular hemoglobin. Hemochromatosis, so that's an increase or an iron overload. So primary hemochromatosis is caused by a genetic defect that leads to excessive iron accumulation in tissues. It results in excessive iron stores, which can damage your organs. And then there is secondary hemochromatosis that occurs due to other causes of iron overloading, like iron loading anemias, like thalassemia, having repeated blood transfusions, taking excessive iron supplementation, and certain liver diseases. Treatment is going to involve therapeutic phlebotomy, so that's the regular removal of blood, and that helps to reduce iron levels. Laboratory test for iron status and anemia. We will use the hematocrit, hemoglobin, red blood cell count, red blood cell indices, total iron binding capacity, also known as TIBC, percent saturation of transferrin, and ferritin, so a whole bunch of them. So the newer test that we are using too is serum transferrin receptor. The levels of the serum transferrin receptor are highest in tissues with the greatest iron demand. Measurement of this helps to differentiate types of microcytic anemia, such as distinguishing iron deficiency anemia from anemia of a chronic disease. Total iron content, so measurement, specimen collection. You're going to collect blood without an anticoagulant for iron testing. You're going to avoid anticoagulants such as citrate, oxalate, and EDTA because they can interfere with results. Early morning specimens are usually preferred because it can have a diurnal variation. The ferric iron is released from binding proteins. So this is the measurement method. Sorry, let's go back. So the measurement method for iron is ferric iron, which is released from binding proteins by acidification of the sample. It is then reduced to ferrous iron by a reducing agent. The ferrous ion becomes a complex with a color reagent for spectrophotometric quantification. Total iron binding capacity, or TIBC. This refers to the amount of iron that could be bound by iron transport proteins in the blood. The main transport protein involved is transferrin, which is kind of nice. It has trans in the name, so transport transferrin, which is normally about 1/3 saturated with iron. Measurement method for this, TIBC is measured by adding excess iron to saturate all available binding sites on the transferrin. And then the bound iron and free iron are then separated to quantify the iron bound to transferrin. There is a calculation for TIBC. where it is TIBC equals UIBC, which is the unsaturated iron binding capacity plus the serum iron. Transferrin saturation, so this refers to the percentage of transferrin iron binding sites that are occupied by iron. The calculation is shown below, where it is total iron content divided by the TIBC times 100%, because your result is going to be in a percent. Clinical significance, this helps assess iron status in the body. Low saturation indicates iron deficiency, and a higher saturation may suggest that there is an iron overload. To measure transferrin, it's measured using nephelometry, a technique that quantifies protein concentration by measuring light scatter, which is caused by antigen-antibody complexes. The ferritin measurement is measured by immunochemical methods like ELISA, which is enzyme-linked immunosorbent assay, or chemiluminescent assays as well. These are your reference ranges. Take a look at those. And these are your clinical significance. So these are the things you're going to want to know. The levels, like iron deficiency, that serum iron is low, transferrin is high, etc. So go ahead and take a look at that. So we have iron deficiency, low iron and ferritin, increased transferrin, and low saturation. Hemochromatosis is higher iron and ferritin due to overload. Low normal transferrin with a high saturation. Chronic infection anemia of chronic disease, so the iron low due to sequestration. Transferrin decreases as a negative acute phase reactant. Ferritin normal or elevated, and saturation is low.